Yes, hello and welcome everyone to the first episode of 2024. And I do hope everyone is having a great beginning to the year and that we will all go through in a very successful, happy, and healthy way. Well, let's start by saying that today we are going to be discussing cases. Rare cases finally are I would say, the very fundamentals of any diagnostics and any patient management. We have with us Dr. Nandini DB. She has been on the channel before, and today also she is with us, and we are very happy to have her. Also, small announcement to welcome our new members, although I also saw Dr. Supriya just become a member. So, thank you very much. There was before this Dr. Leo, Dr. Tio, Dr. Chandan, and Dr. Priya. Now, all the memberships, and which you also can become a member by just clicking the join below, it all helps us and supports us in doing more. Among those is creating the video clinical pathological video atlas of oral diseases that will be a searchable database. And with that, anyway, welcome everybody. And since we are going to be meeting Dr. Nandini, I thought I will share with you that she has a previous lecture that you can go and watch. That was about pediatric neoplasms, a very popular lecture on the channel, and you can find the link in the description also. With this, now let me bring her in. Welcome, Dr. Nandini. Hi.
Greetings everyone. First of all, I would like to welcome to this episode, the new episode in the new year, and all thanks to Mandana madam to give me the opportunity again to present a few interesting cases. Thank you so much, ma'am.
It's really a
I hope
privilege.
it is interesting for the audience.
It will be interesting. I've seen the cases, so yes, they are very interesting. And it's always really a privilege to have you here. And of course, I have slowly cut away with all introductions, but you can see Dr. Nandini is Professor and HOD from RIMS Imphal. Yeah. So she is with us, and we'll listen to the cases.
Greetings everyone. Today I'll be speaking about some uncommon oral lesions. Most commonly encountered oral lesions include dental caries, pulp and periapical lesions, gingival and periodontal lesions, mucosal lesions, odontogenic cysts and tumors, and neoplastic lesions, especially oral squamous cell carcinoma. Sometimes uncommon lesions are encountered. These lesions may mimic a lot of other common lesions and pose diagnostic dilemma. Hence, we have to look for clinical and histopathological clues, and sometimes diagnosis by exclusion is needed. The cases may be classified as straightforward cases, which when we get, we are very happy that we got it right. Suspicious cases or not so sure cases, which may require some investigation such as special stains or IHC procedures. And the third category is never heard or never seen cases. So I shall be discussing some of these cases. Case number 1. 15-year-old female patient came with a complaint of growth on the gums for duration of 1 year. It was slowly progressing and it reached the present size. No symptoms were elicited and no past history was elicited. On examination, there was a solitary growth present in the canine region. It was sessile, firm to hard in consistency, and non-tender. Intraoral periapical radiograph was taken, but there were no significant findings. So we thought that probably it could be a reactive lesion like a peripheral ossifying fibroma or a pyogenic granuloma or a benign tumor. On histopathological examination, we could see a well-defined lesion as seen in figure A. It was having a superficial epithelium and a well-defined capsule indicated by a blue arrow, then a cartilaginous cap indicated by red arrow and a black arrow indicating a cancellous bone. So you could see in the figure B that the cancellous bone had fatty bone marrow. In figure C, you can appreciate the higher power of the cartilaginous cap showing a mononuclear chondrocyte indicated by yellow arrow, and a osteocyte, which is indicated by a black arrow. So there was endochondral ossification. So this was a case of solitary osteochondroma of the gingiva. Now, osteochondromas are surface bone lesions composed of cortical as well as medullary bone with the hyaline cartilaginous caps. WHO has classified it as osteochondral exostosis with continuity to bone marrow and cortical bone. They are mostly considered to be developmental in origin rather than real tumors. Osteochondromas are more common in areas of endochondral ossification. They account to 10 to 15% of bone tumors overall. Most common site are the extremities like femur, proximal tibia, humerus, bones of hands and feet, scapula, pelvis, spine, and ribs. Less than 1% occur in the head and neck area, especially seen in the TM joint region. They include the condylar coronoid processes and mandibular symphysis. Clinically, they appear as slow growing painless mass present for many years, average duration being 6.86 years. They are sessile or pedunculated and firm in consistency. Size ranges from 1.5 to 45 millimeters, average size being 14.7 millimeters. The most common age group is 80% occurring in the first 2 decades. However, the age range is from 3 to 79 years. Jaw osteochondromas are more common in males. They can occur as solitary forms or multiple forms. Multiple forms are seen in conditions like hereditary multiple exostosis or familial osteochondromatosis. If it is a multiple form, it is more common in the females. According to the etiology, there are two variants, the primary variant and the secondary variant. Primary osteochondromas develop spontaneously with no precipitating events. However, secondary osteochondromas can develop either due to childhood radiation exposure or due to trauma. Post-radiation prevalence ranges from 6 to 24%, thereby representing the most common benign radiation tumor. The latency period for post-radiation osteochondromas ranges from 3 to 17 years. The origin is unknown. However, two theories have been suggested. First one is the embryonal theory. According to this theory, cartilage is developed from heterotrophic fetal cartilaginous remnants. Example, remnants of Meckel's cartilage. The second theory is the metaplastic theory. According to this theory, development occurs from pluripotent mesenchymal cells, which are presumed to either arise de novo or stimulated by some type of trauma or chronic irritation or inflammation triggered by plaque and irradiation. Metaplastic change from adipose tissue in the periosteum is also been suggested. Some believe that osteochondromas are developmental lesions, while some believe they are to be true neoplasms, as genetic mutations have been identified both in the solitary as well as the multiple forms. Recently, non random clonal changes of chromosomes in 6, 11, and 12 have been implicated. Hereditary multiple exostosis of familial osteochondromatosis is an autosomal dominant disease with incomplete penetrance, most common seen in females, and the incidence is 1 per 50,000 to 1 lakh individuals. Mutation in two genes have been identified, namely X1 on chromosome 8 and X2 on chromosome 11. Both genes are responsible for heparin sulfate proteoglycan synthesis. Patients with X1 mutations are more severely affected as they develop more number of osteochondromas and they are more likely to develop into malignancies. Radiograph shows an unmineralized soft tissue mass with calcification typical of cartilaginous tumors in 33 to 70% of cases. Densest calcification is seen in the center. Adjacent bones are rarely affected, and you may see a nerve compression or a vascular compression, a deformity, or a bony erosion or bony sclerosis. Grossly, they are well encapsulated with lobular architecture. Histopathology shows a well delineated lesion with bone covered by hyaline or fibrous cartilaginous cap. Chondrocytes, mostly seen with single nucleus, are there in the lacunae and they have a tendency to cluster with large amounts of intervening chondroid matrix. Marked cellularity, binucleated cells, and mitosis may be seen. On the deeper aspect where the cartilage interfaces the bone, endochondral ossification is seen. The degree of mineralization may vary at different areas. The marrow space is usually adipose type. The differential diagnosis include simple exhaustosis, the tori, which are often bilateral and symmetrical, and anatomical location is usually in the center of the hard palate or on the medial surface of the mandible. And they are in the zone of attached gingiva and the growth of which stops at puberty, and no cartilaginous component is seen in these. Osteoma also comes under differential diagnosis. However, this may accompany with growth, expansion, and displacement of teeth, and no cartilaginous cap is seen. Osteoblastoma is attached to the cortical bone and it is mostly painful and fast growing. Again, no cartilage is seen in this. Osteoblastoma is a painful lesion, often shows rapid growth, and again, no cartilage is seen here. Advanced stage of ossifying fibroma may show fibrous component along with the cementosseous structure. So, and no cartilage is seen. So, it can be excluded. Osseous choristomas may show normal lamellar bone in abnormal location, most common in the tongue, buccal mucosa, palate, and gingival area, and no cartilage is seen. Osteosarcomas may show dysplastic features and aggressive clinical behavior. Chondrosarcomas may show binucleation or multinucleation, nuclear pleomorphism, cellular atypia, necrosis, and vascular invasion. It is believed that a cartilaginous cap thicker than or the thickness of which is greater than 3 cm in children or 2 cm in adults indicates the development of a secondary chondrosarcoma. So one has to be very careful in diagnosing this. Gardner syndrome may also be included in the differential diagnosis. However, Gardner syndrome will include other lesions like multiple supernumerary teeth, intestinal polyposis, and cutaneous cysts. So this is how we can rule out the differential diagnosis. Now, IHC and in situ hybridization. Chondrocytes in the mesenchymal layer overlying the cartilaginous tissue may express COL2 and aggrecan proteoglycan, whereas the chondrocytes in the deeper zone are hypertrophic and express COL10 along with endochondral ossification. The tumor cells are positive for vimentin and S100. Toluidine blue stain displays a purple metachromatic color in cartilaginous matrix. Treatment. Surgical excision is the treatment of choice. However, 2% of recurrence has been reported. So, what are the complications? Anesthetic appearance, difficulty in swallowing, speech, food lodgement resulting in malodor, progressive facial asymmetry, prognathic displacement of the chin, crossbite to the contralateral side, just in case there is a TMJ involvement, alteration of the morphology of the condyle, malocclusion with the open bite are all commonly seen if it is involving the TM joint. Bony deformities, fractures, vascular or nerve compression can also be seen. Patients may experience trauma or ulceration when the masticating hard or sharp food may brush the surface of the lesion. So hence these are the some complications, and they may hinder in seating of dentures, especially in denture wearing persons. Solitary lesions may undergo transformation in about 1 to 2% cases, while 1 to 25% chance of malignant transformation is seen in HMO syndrome. Onset of pain, rapid growth of tumor after skeletal maturity, irregular margins, irregular scattered calcifications, internal lytic lesions, erosions, cartilaginous cap more than 2 cm in adults or more than 3 cm in children are suspicious signs of malignancy. Chondrosarcoma is the most common malignant tumor which can occur, and osteosarcomas are also reported. Osteosarcomas especially are seen on pelvis, hip, and shoulder joints. Case number 2. A 48-year-old male patient reported with asymptomatic blood-filled blister over the tongue. The duration was 1 day. He gives a history that while he was having coarse food, the food just brushed over his dorsal surface of tongue and the blister developed, and there was an infilling of with the blood leading to a bigger size. On examination, we could see a well circumscribed blister filled with blood, and it was fluctuant, seen on the lateral border of the tongue. We asked about the previous history. He told that he was a diabetic under medication and hypertension was there, but he was under medication. We asked that whether he had similar lesions elsewhere in the body, and nothing contributory could be elicited. We advised for a blood investigation, and the blood investigations were completely normal. He also told us that there were past episodes on the tongue, on the ventral surface of the tongue, and on the left lateral position. So these ruptured and eventually healed without any scarring. So, what is the clinical diagnosis? We thought about blood dyscrasias, but blood dyscrasias was ruled out because all the blood parameters were normal. So, we thought of mucocutaneous disorder, but there were no lesions on the skin. So, finally, by going through the literature, by taking a second opinion, we got the answer to be angina bullosa hemorrhagica. Angina bullosa hemorrhagica is a rare, acute, benign mucosal lesion of uncertain etiology characterized by short-lived blood-filled blisters. There are various names given for it in the literature. However, Badham was the first person to name it as angina bullosa hemorrhagica in 1967. Pathogenesis is still unclear. It's thought to be multifactorial in origin, and trauma is suggested to be a major triggering factor. Trauma could be from sharp cusps, hard food, coarse food, dental procedures, endoscopic procedures, local anesthesia, even severe shouting, coughing, or sneezing can result in this lesion. Genetic predisposition with increased mucosal vascular fragility has also been suggested. Use of corticosteroid inhalers for more than 5 years, as in case of asthmatics, is also suggested because it causes changes in the collagen, a decrease in the elastic fibers, and epithelium atrophy, resulting in weakened epithelial connective tissue junction or a weak anchorage of mucosal vessels. Systemic diseases such as diabetes mellitus, hypertension, renal failure, rheumatoid arthritis, gastrointestinal disturbances, hyperuricemia, and localized amyloidosis have also been suggested. Our patient had diabetes mellitus and hypertension. Middle-aged and elderly are more commonly affected, and these lesions are very rare in children below 10 years of age. No sex predilection has been reported. However, some reports telling females are more commonly affected, especially during premenstruation period, have been also listed in the literature. Usually, they are single episode, but recurrent episodes have been reported. This onset is very sudden following a minor trauma. The bullae may measure few millimeters to few centimeters. They are red to purple with an ecchymotic halo. Bullae usually show a collapsed roof or spontaneously rupture, leaving an irregular ulcer which heals in a week with no scarring. These lesions do not involve masticatory mucosa. The lesions are more common on the soft palate, buccal mucosa, tongue, gingiva, lips, and rarely seen in the pharyngeal region as well. It is believed that during mastication, there is an increased blood flow to the soft palate via parasympathetic reflex vasodilatation, which might cause the lesions to occur more commonly in the soft palate. Usually, they are asymptomatic. Sometimes pain and burning sensation may be there due to ulceration. Few people report discomfort, xerostomia, tingling sensation, tightness or difficulty in swallowing, choking like sensation, hence the name angina, or gagging reflex if the lesions are present in the faucilar pillars or arytenoids or in the pharyngeal region. Airway obstruction has also been reported with palatal or pharyngeal blisters. Free of flow of blood if the bulla rupture in the laryngeal area, that then there is intubation to be done to avoid airway obstruction. So patients should be made aware of these complications, and they should be asked to rush to the nearest hospital so that the complication is prevented. The diagnosis of angina bullosa hemorrhagica is mainly clinical or history. The biopsy is not mandatory, and some have suggested immunofluorescent staining for IgA, IgG, and IgM and fibrin, which is often negative. Diagnostic criteria for ABH has been given by Ordinio et al. In 2019. So, minimum 6 out of 9 criteria have to be fulfilled. The main criteria include clinically noticeable hemorrhagic bullae or erosion with history of bleeding of the oral mucosa or exclusive oro or pharyngeal localization. Additional criteria include palatal localization, triggering event should be food intake, recurrent lesions should be there, favorable evolution without scarring should be there, painless, tingling sensation or burning sensation should be there, normal platelet count and coagulation profile should be there, and negative immunofluorescence should be there. Histopathology is non-specific. If you take intact bulla, the subepithelial blisters filled with RBCs and few inflammatory cells will be visible. A decrease in elastic fibers and capillary hypertrophy in past time can be appreciated. And if the bulla is ruptured, an ulcerated histopathology of an ulcer can be visible. Now, differential diagnosis include vesiculobullous lesions, and a whole lot of vesiculobullous lesions can be taken into differential diagnosis. There will be presence of skin lesions, histopathology, and the immunofluorescent studies may be performed to rule out the lesions. Blood disorders, which are like thrombocytopenia, to name a few, they might be considered, but the clinical features of petechiae, ecchymosis, epistaxis, or gingival bleeding may be there, and the blood parameters are usually abnormal. Drug-induced eruptions may also be considered, but there is always a history of allergy, and eosinophils may be evident in the histopathology. Amyloidosis may also be considered, but there will be deposition of amyloid, which can be appreciated by Congo-red staining. What is the treatment? Treatment includes mouthwashes containing chlorhexidine dichloroconate thrice daily to prevent the pain and secondary infection. And benzidamine hydrochloride mouthwash has also been suggested. Ascorbic acid can be taken, and avoidance of trauma is the best. Avoidance of trauma due to coarse food or avoiding unnecessary treatment procedures, grinding of sharp teeth should be done. And the patients have to be monitored for their systemic illness. Oropharyngeal lesions should be monitored and carefully surgical intervention have to be performed. A 35-year-old male patient came with a mass on the left side of the upper lip, duration of 10 years. It was small to begin with and slowly progressed to the present size. It was asymptomatic. The patient wanted to get it removed for aesthetic concerns. On examination, it was a firm inconsistency and it was a subcutaneous mass. So we thought that it could be a benign tumor of connective tissue origin or a benign salivary gland tumor. Now, surgical excision was performed, and these are the pictures of it. As you can see, the lesion is well circumscribed and it is yellowish white in color, and on cut surface it was glistening. Now, this was a histopathologic examination. On low power, it showed a well defined capsule represented by a red arrow and sheets of epithelial cells arranged in sheets seen in blue arrow, and few epithelial cells were arranged in ducts seen by black arrow. A chondromyxoid material, the pseudocartilage, was also evident, represented by the yellow arrow. Further, in high power, we could see some tubulocystic structures or ducts lined by double layer of epithelial cells as seen by the red arrow, and there was adjacent stromal hyalinization seen as represented by black arrow. There were cystic dilatations filled with keratin flakes and squamous metaplasia. So this was a case of apocrine variant of benign chondroid syringoma. We initially thought it to be pleomorphic adenoma, but since the ducts were not very commonly seen, such ducts with dual layer, we took an opinion from our general pathology colleagues, and they gave the diagnosis of apocrine variant of benign chondrome syringoma. Now, before going into the lesion, what it is, we should know the histology of skin. So, the sweat glands can be classified as eccrine and apocrine. The eccrine sweat glands are usually seen throughout the body. They are usually present in the deep dermis, and their ducts open into the surface of skin. The secretions are less viscous, and they function in regulating the body temperature, waste removal, and stimulated during emotional stress. Their function starts soon after birth. Apocrine glands are, however, seen only in hair bearing areas. Mostly they are subcutaneously present. Their ducts open into hair follicles. Their secretions are more viscous in nature, and they are stimulated during emotional stress or sexual excitement, and the development begins at puberty. Now, what is chondroid syringoma? It is thought to be a benign tumor derived from skin appendages, especially the sweat glands. Billroth was the first person to describe them in 1859, and he termed them as pleomorphic adenoma of the skin. Hurst and Helwig in 1961 first described this name, the chondroid syringoma, and replaced the terminology for pleomorphic adenoma of the skin. These tumors are very unique because the incidence is less than 0.098% of all primary skin tumors. They usually are seen as solitary, well delineated, slow growing, painless, non ulcerated sub or intracutaneous nodules, sometimes with surface telangiectasia and sessile base. Chondroid syringioma, the benign form and the malignant form, two forms have been described. Benign form is more common in males, while malignant form is more common in females. The age group ranges from 20 to 70 years, but more common in the middle and the elderly age group. Rare in children. Nose is the most common site, followed by cheek and upper lip in the head and neck area. They are also seen in eyes, eyelids, hands, foot, axillary areas, abdomen, penis, vulva, scrotum, scalp, and back. Some chondroid syringiomas, as in case of foot, may be preceded by trauma. These are this is a compilation of the benign chondroid syringomas in the lip. We had published the case report, so the compilation is there in that. So very few cases are seen on the upper lip. Differential diagnosis may include other lesions such as dermoid cyst, epidermoid cyst, neurofibroma, compound nevus, histiocytoma, pilomatrixoma, dermatofibroma, basal cell carcinoma, seborrheic keratosis, and the most common confusion with salivary gland tumors. So, this particular lesion shows adnexial ductal epithelium with chondromyxoid stroma. It shows bilayered tubular cystic structures inner layer of cuboidal cells, and peripheral layer of flattened cells. The cells of the peripheral layer show proliferation into the stroma, which have a mucoid or faintly basophilic appearance. Chondroid, myxoid, fibrous, and even osseous stromas can be seen with epithelial structures typically having epicrine or ecrine nature, although folliculosebaceous elements can be seen. Histopathologically, there are five criteria have been given for the diagnosis of chondroid syringoma. Nests of cuboidal and polygonal cells, intercommunicating tubulo-alveolar structures lined with two or more rows of cuboidal cells, ductal structures composed of one or two rows of cuboidal cells, occasional keratinosis, and a matrix of varying composition. Two histological variants of chondroid syringoma have been described by Headington. Ecrine type, as you can see in the picture here, ecrine type will have ducts which are smaller and have smaller round lumens lined by single layer of cuboidal cells arranged evenly within a myxochondroid stroma. The apocrine type will have larger ducts. They are irregular and haphazard in nature and interconnecting with one another and are lined by double layer of cells, the inner cuboidal and outer flattened cells. The inner layer usually expresses positivity for epithelial markers such as cytokeratin, epithelial membrane antigen, and tarsioembryonic antigen, while the outer layer expresses positivity for mesenchymal markers such as vimentin, S100 protein, neuron specific enolase, glial fibrillar acid protein. Mills suggested that chondroid syringomas are monoclonal tumors. That means one cell is giving rise to all the various structures. So this can be the example. Probably it is the myoepithelial cell which is playing a role similar to the pleomorphic adenoma. The chondroid areas were earlier believed to be derived from the myoepithelial cells. However, recently it was concluded to be true cartilaginous tissue with typical chondrocytes, confirmed ultrastructurally in the subsequent studies. The presence of Merkel cell with CK20 positivity is also there in this particular lesion, telling that probably Merkel cells are the site of origin, cells of origin. The immunohistochemistry may vary depending on whether it is a acrine type or a apocrine type. Now, differential diagnosis, most common differential diagnosis would be a pleomorphic adenoma. So, how do we differentiate this from pleomorphic adenoma? Benign chondroid syringoma arises from sweat glands, while pleomorphic adenoma arises from salivary glands. Benign chondroid syringoma is a rare tumor, while pleomorphic adenoma is the most common benign salivary gland tumor. Histogenesis, benign chondroid syringomas arise from myoepithelial cells or Merkel cells, while pleomorphic adenoma, as we know, arise from intercalated duct reserve cells or myoepithelial cells. Site, benign chondroid syringoma arises mostly in the extremities and very few are in the head and neck area. And pleomorphic adenoma, it is rare in other sites, more common in the head and neck area. The age group is nearly the same. The sex, if we take benign chondroid syringomas occur in males, malignant forms occur in females, while pleomorphic adenoma is more common in females. Size, benign chondroid syringoma is usually less than 3 cm. However, pleomorphic adenomas are usually in the range of 2 to 6 cm. The histopathology will show some adnexial structures such as hair follicles, sebaceous glands, or the sweat glands, and the ducts with dual layer in case of benign chondroid syringomas. And there is absence of acinar cells in benign chondroid syringomas. However, in pleomorphic adenoma, you can see serous and mucous acinar cells and the epithelial cells arranged in sheets, strands, and ducts. However, adnexial structures are not seen. Now, the malignant chondroid syringioma may arise either de novo or in a pre-existing benign chondroid syndrome. So it shows characteristics of aggressiveness, metastasis, and recurrence. You may also appreciate increased mitosis, cellular and nuclear pleomorphism, invasive margins, satellite tumor nodules, necrosis, fixation to the underlying structures, excessive mucoid stroma, poorly differentiated chondroid components, and rapid growth size more than 3 centimeter, which might be seen in a malignant form. Malignant forms are more common on the trunk and extremities, and as said before, they are more common in females. And there is lymphatic spread. The lymph node metastasis can occur in 48% of cases, and distant metastasis to lung, bone, and brain can occur. So, what are the investigations? The MRI, ultrasound, and CT can be done to know the origin, depth of invasion, and relation to the adjacent structures. FNAC has also been tried using various states. However, it's not very confirmative. Definite diagnosis is established only through histopathological examination. Now, treatment, the surgical excision with a rim of 4 millimeter normal tissue is a treatment of choice. For malignant forms, surgery along with adjuvant radiotherapy with or without chemotherapy has been suggested. Dermabrasion, electrodissection, vaporization with argon or carbon dioxide laser has also been suggested. The recurrence is around 18%. Due to paucity of these cases, the accuracy and efficacy of various treatment modalities are yet to be ascertained. Case number 4. A 43-year-old male patient came with a complaint of tooth pain on the right lower back tooth region. On examination, he had multiple root stems and carious lesions. Along with this, there was presence of marfanoid habitus. Multiple nodules on the conjunctival surface of the upper and the lower lids were seen. The lips were diffusely enlarged and everted and bumpy on palpation. There was a history of thyroid carcinoma, and thyroidectomy was done around 20 years back. History of constipation was there since childhood. There was no history of similar cancers or any abnormality in his family. Intraoral lesions showed multiple nodules on the dorsal surface of the tongue, on the buccal mucosa, and on the labial mucosa, as shown in this diagram. On taking a orthopantomograph, we could elicit multiple root stems, a midline diastema in the maxillary anterior region. You can see that the mandibular canal is enlarged and multiple root stems were present. So histopathologic examination was done by one of the nodule was taken for biopsy and subsequent observed under microscope showed bundles of disorganized and tortuous nerve fibers surrounded by a thickened perineurium, which was suggestive of mucosal neuromas. Numerous bundles of elongated cells with wavy dark nuclei were evident. So, what was the diagnosis? Taking into consideration the clinical pictures and the histopathological pictures, the diagnosis was given as multiple endocrine neoplasia syndrome type 2B. So, multiple endocrine neoplasia can be differentiated or can be classified into MEN1, MEN2A, and MEN2B. MEN1 includes primary hyperparathyroidism, pituitary adenomas, and pancreatic tumors. MEN2A includes medullary thyroid carcinoma, pheochromocytomas, and primary hyperparathyroidism. MEN2B includes medullary thyroid carcinoma, pheochromocytomas, marfanoid habitus, and mucocutaneous neuromas. And rarely, MEN2 can be associated with Hirschsprung disease, that is, with the megacolon, and cutaneous lichen amyloidosis. The synonym of this lesion is multiple mucosal neuroma syndrome. It was first described by Wegenmann in 1922. The complete syndrome with mucosal neuromas, pheochromocytomas of non-cancerous tumors of adrenal gland, and medullary thyroid carcinoma may be evident in only in 50% of these cases. The mean age is said to be 18 years for this particular lesion. Now, the actual epidemiology is unknown, but the prevalence is estimated to be 1 in 6 lakh individuals. Men 2B shows prominent extraendocrinal features, a more aggressive presentation of the medullary thyroid carcinoma, and a lack of primary hyperparathyroidism, unlike in men 2A. Medullary thyroid carcinoma develops within the first year of life, and the patient dies usually before the age of 30 years. Etiology, it is said to be due to de novo mutations, and some sporadic mutations also are seen. It is usually transmitted in autosomal dominant mode of inheritance. About 95% of men to be are due to germline point mutation in the red proto-oncogene on chromosome 10. Now, red protein is expressed from the neural crest cells, including C cells of the thyroid, adrenal medulla, and the enteric ganglion, and encodes a member of the receptor tyrosinase kinase family of transmembrane receptors. There are various subtypes of men, as mentioned before. So, men 2A, familial thyroid carcinoma, and men 2B. The incidence is said to be like this: 80% of them are usually men 2A, so it is the most common form. Then comes 15% of familial medullary thyroid carcinoma, and the rarest form, the men 2B, is said to account for only 5% of cases. The complete syndrome with mucosal neuromas, pheochromocytomas, and medullary thyroid carcinoma is very rare, and it is seen only in 50% of cases. And 10% cases will show the neuromas and pheochromocytomas. And some manifest only with mucosal neuromas and medullary thyroid carcinomas. So the medullary thyroid carcinoma associated with men 2B is said to be more aggressive and more dangerous. So the clinical characteristics, apart from these, you also see enteric ganglioneurofibromatous, then neuromatosis, skeletal abnormalities of the spine, pes cavus, thickened medullated corneal nerves, and thickened lips. Marfanoid features are also seen in these cases. So, men 2B patients do not show parathyroid disease. They show the remaining things, and these are all the things which can occur. I have already mentioned about it. Along with that, gastrointestinal symptoms such as pain, diarrhea, constipation, bloating, and megacolon has to be kept in mind. The oral findings include mucosal lesions, mucosal neuromas, especially on the tongue. That could be one of the earliest signs of this disease. So, multiple neuromas can be seen on the tongue, buccal mucosa, and medullary thyroid carcinoma, as I told, it is much more aggressive, and there can be bilateral presentation of the pheochromocytomas. Intraoral features also include high arched palate, gingival hyperplasia, prognathic mandible, spacing of the anterior teeth, especially the diastema between the maxillary incisors is one of the earliest signs. So one has to be vigilant to identify this lesion in the early stage. So these are some pictures depicting the thyroid cancer, thyroid carcinoma there, and the marfanoid features, high arched palate, neuromas on the lips and the tongue, multiple neuromas on the conjunctival, on the lower eyelid there, and the megacolon. You can see the enlarged colon. So what is the diagnosis? Clinical findings are the most important ones to identify this disease. Annual screening has to be done because the patient may develop these symptoms in any stage. Serum calcium, parathyroid hormone, calcitonin, carcinoembryonic antigen, epinephrine, norepinephrine, and dopamine should be done. Urinary fractionated concentrations of catecholamines can also be elicited. Thyroid, adrenal, GI scans, MRIs, and CT scans are required for the diagnostic workup. Biopsy of the mucosal lesions have to be done to confirm the mucosal neuromas, and antenatal diagnosis like pre-implantation genetic diagnosis, prenatal chorionic villus sampling, or amniocentesis can be done to prevent this disease. Histopathology, if you see the medullary thyroid carcinoma, then you will have to take the biopsy from there as well. While mucosal neuromas, as I described, may show bundles of disorganized or tortuous nerve fibers with elongated cells showing wavy dark nuclei surrounded by a prominent perineurium scattered throughout the submucosa. So, differential diagnosis includes traumatic neuroma, palisated encapsulated neuromas, Morton's neuroma or neurofibroma. And here, there is no history of trauma. So, mucosal neuromas have distinct clinical history. Along with these neuromas, there will be other features also which will help in excluding the other diagnosis. Management. Multidisciplinary approach is essential in this case. Early diagnosis and recognition of the phenotype is absolute essential. Adequate surgery has to be done, and appropriate genetic counseling with genetic screening has to be done at the appropriate time. So, to conclude, I would say that majority of the time the patient himself will be giving the history, so history plays an important role, so we need to listen to the patient thoroughly. He himself will tell half the diagnosis, so it is very important. We may make mistake and we may confuse these lesions to other common lesions, and in such a case we should never give up. We should practice to imagine them, to imagine the particular pattern, to identify a particular pattern. If we think that we already know everything, it is not possible. So you should keep learning throughout. I said that we will not be able to learn further if we think that we are right at all the time. So read continuously, update yourself. If you do not expect the unexpected, you will not recognize it when it arrives. As it is said that the eyes can't see what the mind doesn't know. So that is why we have to read, you have to investigate, and then only arrive at the proper diagnosis. The greatest lesson I have learned in life is that I still have to learn a lot. Thank you all.
Right. That was a very, very nice lecture, in fact, and a very nice set of cases. From what I can see, Dr. Nandini is with us, even if we don't have her. Okay, and she's gone. All right. Okay. Yes, she is there, even though it is just by voice. I think, Nandini, can you hear us? Right. So there was this last comment, I guess, from Professor Joss that did not know that marfanoid features were so frequent in men 2B as well as the other anatomical intraoral features. And Nandini, I think, has responded to that. Yes, marfanoid habilitus is common. It means decreased upper and lower body ratio. Cool. Then we have something from Dr. Ghosh. Excellent presentation, ma'am. The cases were really interesting. Yes, in fact, they were very, very interesting. And thank you for watching. So, is there anything else? Let's see. Okay, in case you do have questions, please type them in because she is responding on the YouTube chat itself. In the meanwhile, let me tell you all what is next week. Right. So next week we are going to have a one of the thinking outside the box series. Now this series is both a um, podcast and a live play and a live stream. So, in case you want to just listen, you can. We'll be meeting with Professor Hans Zollner. He is a very well experienced and a very senior researcher and academist, and he has only recently given up full time in academics, although he's still there. And he has been, if you have watched on LinkedIn, if you know him on LinkedIn, he is very much involved on discussions about the academic institutions and their role in ensuring that there is ethics and there is the whole standard that we come to expect of the doctors is actually preserved. So we are going to have a meeting with him. This will be really very interesting. So I do hope you will meet us, and it is of course at the same time. And let's see, is Nandini back or are there any questions? Okay. Nandini is saying, okay, that Dr. Eliza is saying thank you, hello. And okay, let me at least bring it on her certificate. So, right.
Other
Okay. Nandini, you're there. Are you there? Oh, no. Okay. And Nandini also is saying thanks to everyone. And okay. Right. And all right. Do you really want to put your email up there? Okay. Right. So if you do want to get in
Thank you
contact
so
with
much for
us,
the
you can do
opportunity,
that.
ma'am.
Yes, she spoke. I could hear you, but I don't think anyone else heard you, Nandini. Right. Okay. All right. Thank you, everybody. And it's been wonderful having Nandini here, of course. And it's been wonderful having all of you here for the first session of 2024. Even though we had some hiccups, we hope that this is not going to be the trend going forward. Right. So, okay, we have some. Okay, Nandini is here. So, Dr. Wangru, listening to Ma'am Nandini lecture after a decade. Thank you, ma'am, for your wonderful lecture. Right. Dr. Professor Joss, yes, I will again share it. So, where did it go? Right. This is going to be next time's talk, academia, and the role of the management of the academic institutions in the destruction and repair of academia. Yes, so I do hope you will definitely join us. And okay, now my page is good. Right. Thank you, Gururaj sir. Yes, thank you for attending. And right, I think have I missed some? Okay, yes, that was Nandini saying thank you to her clearly ex-student. And let me hide this. Right, Nandini, you're not here to. I mean, I know you are there, but well, uh, so thank you. And this is one more certificate for you that you can add in your collection. Oh, Nandini, huh? We can see you.
Thank you, ma'am.
Today I felt like playing I Spy with my little eye. Nandini sitting there or not sitting there. Okay, okay, I guess we are done. Was there anything among the questions that you want to address specifically
Hello,
before?
ma'am. Finally. Yeah. Thank you so much
Yes,
for the opportunity, ma'am. Hope the audience enjoyed it. With so much difficulty, finally, I logged in.
yes, I know, I can see. So, anyway, is there anything within the questions that you want to address that sort of we did not talk about?
Yes, ma'am. Thank you so much again.
Okay, cool. Right. So, thank you, everybody. We will be meeting you coming week. Remember, the time is
Actually,
changed. Yeah,
these are
tell.
quite rare cases, ma'am. And if we are very alert now, we can recognize or catch these cases at a very early stage, especially like men 2B and all, because medullary cancer, it might lead to death within 20 years or 30 years of age. So if you catch them early, then you can also treat the megacolon, all the serious complications can be prevented. So listening to the history and being a vigilant clinician to recognize these conditions in the early stage is very, very important. So that is why we should be reading even the rarest of the rare diseases we should know, ma'am.
That is true. That is where it is the most difficult, no, is to keep on staying updated with the rarest, with things that change, and not only just rare, but sometimes things also keep changing as we find more. That's why I think being a diagnostician, in the sense actually reporting pathology or remaining committed to reporting cases, is essentially a full-time job. I don't think it's something you can do as a passing by thing. Yeah, which is part of the reason I don't do it anymore. Right. So, okay, we are done. We have shared your certificate. We have shared next week's event. We have, I believe, said thank you to everybody, and thank you again in case we didn't say it. And lovely having been
Thank you
here.
so much, ma'am.
Yes, lovely being with you, Nandini, always. And yes, see you all. See you next time.
Thank you, ma'am. It's
Bye.
always a pleasure being with you. Bye, ma'am. Bye.